Good afternoon, everybody. Thank you so much for joining us for today's webinar, Supporting Family Caregivers in Long-Term Care, Straightening Palliative Care Together, hosted by Family Councils Ontario. My name is Taeyong Jung, and I am the Bilingual Events Manager at FCO, and I will be your host for today's webinar. Before we start, I would like to take a moment to recognize the land on which we are gathered today. So I am currently joining from Toronto, which is seated on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. It is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. At FCO, we value so much the work and the people that have come before us, and we always strive to respect and always include the work of Indigenous people with our mission. So I just wanted to share a few logistics and housekeeping rules before I introduce our guest speakers for today. So if you have been to FCO's events in the past, you'll notice that it is in a different format today. We used to be on Zoom. We are now going to be on Microsoft Teams, and I see a lot of people in the audience, so I'm happy that everybody was able to join. So this is the first webinar we're doing on Microsoft Teams. We're testing a few things, so please be patient with us. You'll notice that all of the features like Q&A and chat are active. So if you have anything to share during the webinar, please feel free to use the chat to share your reactions, comments, anything. And if you have questions for our guest speakers, I invite you to use the Q&A box to ask your questions. There will be a period for questions for it to be more interactive. Um, at the end of the presentation. If you feel more comfortable asking your questions like live, I can also give you that feature if you like raise your hand and you want to turn on your microphone. So that's also an option. You'll notice that the webinar is being recorded, so we try to record all of our webinars so you can view it afterwards or share it with anybody in your circle. So it will be available on Family Council's Ontario YouTube channel next week. It will also be featured on our weekly e-bulletin. If you haven't subscribed to our weekly e-bulletin, I encourage you to do so. We send them every Wednesday. You can visit fco.ngo to subscribe to the e-bulletin. So it is now my pleasure to introduce today's guest speakers. First, we have Amit Arya, who is a leading palliative care physician dedicated to improving long-term care through innovative clinical models, education, and culturally safe practices. He directs the Specialist Palliative Care and Long-Term Care Outreach Team at Kensington Health and has co-developed wisely used provincial training tools that strengthen equity, cultural humility, and qualitative palliative care. His national leadership, research contributions, and policy work have earned multiple awards and invitation to advise on federal legislation and national long-term care standards. And we also have Colleen Webber, who is an investigator at Bruyere Health Research Institute in Ottawa and the Bruyere lead of OnSpark, a long-term care data platform supporting innovation and quality improvement in the long-term care sector. Her research program focuses on three interconnected areas: long-term care, palliative care, and mental health. Across these domains, she examines how health systems can better support older adults and people living with complex chronic conditions. So, Colleen and Amit, the floor is now yours.
Thank you for the introduction. I'm going to share my screen, so just bear with me for a moment. Okay, everybody seeing the full size PowerPoint?
Yes.
Thank you. Okay. So I will take it away. So as introduced, our presentation today is looking at supporting family caregivers in long-term care to strengthen palliative care. I will be leading us through the presentation along with Amit. So I will go forward. Amit, do you want to add anything to your introduction?
Yeah, maybe I'll just say thank you to Tae Young as well for giving Colleen and I the opportunity. What I'll add is that as Tae Young has mentioned, I'm a palliative care physician, but my passion is really working in long-term care homes, and currently I provide consultative palliative care supports to 10 different long-term care homes in the Toronto area, and have led and developed these two programs, which provide outreach specialist services to long-term care homes. So that's the only thing I really wanted to add. And maybe I'll add one more point. And just to say that today's session is really less so, if I can speak on your behalf, Colleen, it's less so about us. And it's not meant to be a didactic sort of lecture, but it's more meant to be learning about all of your experiences and thinking about future direction in terms of how we can better support and work with Family Council, Family Councils Ontario, and hopefully support family caregivers across the province with a palliative approach to care in long-term care.
Great, thank you. So I don't really have much to add to my intro, so thank you, Tae Young, for that wonderful introduction. Just to add that I'm, very thankful for the opportunity to be here and to, share some of our knowledge and think about that ways that we can work together with Family Caregivers Ontario. Before we get going, we just have a conflict of interest slide to acknowledge I have no conflicts to declare, and Amit has just noted his potential conflict there. So throughout the presentation, we're going to be doing a couple of polls to gauge participants' experiences and perspectives and priorities on palliative care and long-term care. So I've just dropped this slide here. This is the, you can use the QR code to join via your phone. There's also a website that you can join via the code here. This will also come up later in the presentation, so don't feel rushed to kind of scan it now, but just to give you a sense of what's to come, and all of the information that we get will be, it's all anonymous, so we won't know who's providing what feedback, if that's important to anyone. So now I'm going to pass it over to Amit, who's going to present the first few slides.
Yeah, thanks so much, Colleen. So maybe we'll start by grounding ourselves and thinking a little bit about why this conversation is important. Firstly, we wanted to start by sharing our experiences with you. So what we're seeing in long-term care from my perspective as a clinician who once again works across these 10 different long-term care homes, and I've worked in many others through my career as well. And from Colleen's perspective as a health services researcher, thinking about the long-term care system. Secondly, and most importantly, we really want to learn from your experiences and your expertise, because I'm sure you are seeing things and experiencing things that we don't always see. Third, we're hoping to identify gaps together and hopefully find some areas of common ground, and then think about how we can build together to support family caregivers in their essential role in long-term care homes with navigating a palliative approach to care. Next slide. All right, so we'll start by just trying to develop some common language in terms of how we speak about palliative care. And I'll start by this question that often comes up. And actually, whenever I see a resident in long-term care and meet with their family caregivers or, with their family caregiver, we always start by this, trying to answer this question together in terms of what palliative care is, and also what palliative care is not. And, the first thing that everyone really thinks about when they hear the words palliative care is they think immediately that it means end of life care. And I'll start by explaining that, of course, that is part of palliative care, but the actual practice of palliative care is much, much broader. Palliative care is really a team-based approach to supporting anyone who is living with a serious illness, and especially an illness that is incurable. Palliative care can and should begin early, sometimes from the time of diagnosis, and it can be provided alongside treatments that are meant to prolong life. It is also not location dependent. So as I'm sure you all know, long-term care homes can provide palliative care, but you can also receive palliative care in a clinic. You can receive this type of care in a hospital setting as an inpatient. You can receive this type of care in a palliative care unit or a hospice. So at its core, palliative care is about improving quality of life and relieving suffering, regardless of the amount of time that someone may have left. And it's also about supporting family caregivers and the team in a better way. So to summarize, really the essence of palliative care is actually helping people to live as well as possible for as long as possible. So I just wanted to summarize that and make sure that we have some common understanding of at least about what I mean when I talk about palliative care. Next slide. Okay, so I think we talked about many of these points that are already on the slide. And once again, I will re-emphasize that it doesn't have to be provided exclusive from treatments to extend life. So rather than thinking of medical care or active care or palliative care, we should be thinking, and rather than thinking of this either or approach, we should be thinking of both and, which means that somebody can receive hospital care or even care in the emergency department and palliative care. Somebody can receive care in long-term care that's meant to support their responsive behaviors and palliative care. Somebody can receive cancer therapy and palliative care. So once again, it can and should be provided alongside treatments to extend life, and it's about living well until the moment of death. Next slide. Okay, I think I already talked about this, but I'll emphasize sort of one other point on this slide here, which I think is important and we will discuss later on in today's presentation, which is the last point on this slide, where we talk about how palliative care, many people think this starts from the point of advanced care planning. And advanced care planning is about preparing to make future decisions, which I believe is an essential role for family caregivers in long-term care, where often it is very helpful to be prepared to make common future decisions that may arise. And that is also part of the palliative care approach.
Okay, so now I'm just going to speak to why palliative care is so important in long-term care and palliative care for long-term care residents. So we know that, for nearly everybody who enters long-term care, it will be their last home before death. So individuals go into long-term care, and the vast majority are not returning to the community. They're not returning to their prior residence, but rather it is their home before death. Everybody who enters long-term care will eventually experience declining health after they go into long-term care. So the trajectories are not necessarily the same across all residents, but individuals will experience changes in their cognitive and physical health that will impact their care needs while they're in long-term care. The median life expectancy after entering long-term care is about 18 months. So about 50% of people who have gone into long-term care will die within 18 months of admission, although there is a lot of variability in that number. So some individuals will enter long-term care and die shortly afterwards. Others will go into long-term care and live there for many years. The annual mortality that we see in long-term care residents, it varies depending on the data source that you look at. It's estimated at about 27 to 52%. So all of these statistics kind of come together to point to, the fact that this population, the long-term care population, is a population that has a very high palliative care needs, has a lot of complex health conditions that could benefit from palliative care, and really points to the need to have a palliative approach integrated into the long-term care system. At the same time, we're seeing a lot of gaps in how palliative care is being delivered within long-term care. And just to kind of highlight this is a fact or some data from the Canadian Institutes for Health Information. So they have estimated that only 19% of long-term care residents received palliative care in their long-term care home in their last year of life. We think that this is probably a bit of an underestimate based on the data that it's coming from. However, when we look at this population and their healthcare needs and what their healthcare conditions that they're facing, probably at least 90 to 100% of them could benefit from palliative care. So there's quite a gap between what's actually happening in reality versus, where the needs are and what the reality should be. We also know that 90% of substitute decision makers, when they were polled, so 90% of substitute decision makers for long-term care residents who have advanced dementia, state that comfort is the primary goal of care. So what they want to see for their residents is, that we're managing symptoms, we're supporting their quality of life, and all of these are goals that are very much aligned with a palliative approach. So I'll pass this over to Amit now to talk about the gaps that we're seeing in palliative care.
Yeah, and before we get into that, because as I promised, we're going to try not to make this didactic. Does anybody have anything they would like to say or they would like to add? Anything you want to put in the chat, feel free to do that. I hope it's possible. Feel free to unmute yourself as well if you want to share something at this point.
We do have a question in the Q&A box. I don't know if you want to wait till the end for all the questions in the Q&A box, or you just want to just like go.
Oh, yes. Oh, yes, I see it now. Yeah, I missed that. Sorry. Thanks for pointing that out, Tae-Young. Yeah, so this is a message from Crystal. Thank you so much for this question. Do all long-term care homes have an expert like this doctor to consult with in palliative care? Well, first of all, thanks so much for considering me an expert. I feel like I'm still learning about palliative care. Like any other field of medicine and healthcare, there's always a lot to know and to learn. But just to answer your question, unfortunately, that's not the case. In my experience, having access to palliative care consultative services is quite rare in Ontario. And that's something that I hope personally will change one day, where I feel that in certain situations, which perhaps may be challenging for the long-term care home staff to manage, whether it's respect to advanced care planning or undertreated symptoms, or just, even increased support and reassurance for family caregivers, I truly do believe that, palliative care consultative services can act as an extra layer of support on top of the care that's already being provided by the long-term care homes. And I think in the future, there will be more research, to come on this area of study, specifically on having palliative care specialists working in long-term care. Colleen, anything to add?
No, I would just echo what you're saying. I think, there's issues of, is there access, and then where are the barriers in terms of, do the homes, do they have these types of resources available, and do they know how to access them?
Yeah, absolutely. Right. And our aim, maybe one thing I'll add, because this is the work that I do actually day in and day out, is going into different long-term care homes and seeing people by referral, is that the aim of myself and the teams that I work with, the other palliative care physicians, is really we meet long-term care home staff and family caregivers where they're at. So we come in to provide, once again, recommendations and suggestions based on the situation without judgment, right, as it should be. So I just wanted to add that. Okay, so thank you for that question. And maybe I'll move to just a shared discussion actually around some of the gaps that we're seeing, where we wanted to obtain your feedback and, sort of, see if you agree with, our perception of these gaps, or if you're thinking differently. We would love to hear from you. So we'll go to the next slide, please. All right, so the first gap, I already kind of addressed this. It's really related to the framing of palliative care. To be very frank with all of you, this is this is actually a gap, honestly, across the healthcare system in many non-palliative care specialized settings, including long-term care, where we use the word palliative care and often we ration palliative care to when we think somebody is at the end of life, maybe in their last days or weeks, sometimes months, or when somebody is deemed to be, quote, comfort measures only. And I'll share with you that means different things to everyone, and it means different things to different people. But it's essentially a point where maybe there's an agreement that life prolonging measures would not be valuable or would no longer be provided. But as I described earlier, this approach of rationing palliative care to the very end of life can limit early support and integration. So sometimes that support and that conversation may not happen as earlier as it should. So maybe the question for all of you is, what are you seeing in the long-term care homes where your loved ones are? When have you seen palliative care introduced or first mentioned?
I'll just say also, if anybody would like to open their mic, just let me know. You can raise your hand and I'll give that access. If not, please feel free to answer this question in the chat. There is a question that came in the chat, Colleen. I don't know if you were able to see. It was referring to what you were talking about. What does 19% of receiving palliative care, what does that consist of? Is that about medication? What is that measuring?
Yeah. So sorry, I can't see the chat right now with sharing my screen. So if there are questions that are targeted at me, maybe just Taeyong or Amit, feel free
Yeah.
to bring them to my attention. I mean, the 19%, so there's data that's collected throughout the course of long-term care admissions, and it's standardized data, and that's where that number is coming from. So it's, that's why I say it's probably an underestimate, because it's kind of dependent on the person that's doing the documentation, kind of noting that palliative care has been delivered. It's dependent on the person doing the assessments that's used to kind of compile these reports. So it's not a perfect estimate, but it's what we have. So that's also what, one of the challenges when we try to think about palliative care and long-term care is actually how do we actually measure it? So it's an underestimate. It wouldn't capture, it was looking at specifically care within the home. So if somebody goes to hospital, we're not getting at it from that perspective. But it's kind of an imperfect measure.
All right. Thanks, Colleen. And I'm also seeing in the chat, Wendy has written end of life. So I'm assuming that's the answer to the question in terms of when Wendy has seen palliative care introduced or first mentioned in the long-term care home where her loved one is. Is there anyone else who wanted to share their experiences? Like, or does anyone else have a sort of a variable understanding or appreciation of what's happening in their long-term care home? Okay, so thanks, Pauline. I'm seeing your response where you're adding that you've seen this being introduced when significant decline happens. So my comment to that as a specialist is that, that's okay. It's always better late than never to have this conversation, but sometimes it's challenging when we wait for the decline to happen. And it's always better to have a proactive approach where we are already prepared for common causes of decline and having conversations and having a shared understanding of how we would manage those situations in line with someone's wishes. And I see, another comment from Crystal. My mom has been in a retirement home, then long-term care past 4 months. The first person to suggest palliative care was the geriatrician on call in Emerge the last time she went in. So thank you for bringing that up, Crystal. That's also my experience. And frankly, what you're sharing is actually one of the core reasons as to why I no longer work in the hospital, because I see, and I've seen many people over my career who were coming to the hospital and then seeing a palliative care specialist and having this conversation about what that would look like. And then there was a plan that was implemented upon discharge from the hospital in the long-term care home with the guidance from the palliative care specialist. So I thought, why not just go to the long-term care homes proactively and have these conversations early in a setting where hopefully the residents are a lot more comfortable, a lot more familiar. The staff, as you all know, really get to know the residents. And I just felt that was so much better. And that has been and continues to be my consistent experience. I'm seeing Alma writing that at our home, we have that conversation as soon as they move in. Yeah, so great, right? We can see here, just even from some of the feedback we're receiving in the chat, that there's some variability, and we'll talk a little bit about that in one of the future slides. Jacqueline has written end of life care and when pain cannot be managed. Yeah, so I think we've had this conversation that it's very important for us, hopefully, to have this conversation earlier than end of life. Thanks everyone for your feedback. Lori has written, I'm very fortunate to work in a long-term care home where our medical director and staff across all departments, including environmental, dietary, in addition to PSWs, RPNs, and RNs, are very passionate about palliative care, end-of-life care, and advanced care planning from day one. So, wow. Thank you so much for sharing that experience, Lori. Kudos to you and kudos to everyone in the long-term care home that is very passionate about this care. It is really so important. Definitely from what I'm sensing, I can see, and I think we can all see there is some variability in terms of how palliative care is introduced and first mentions. Just to summarize, I think for some people, maybe it is more mentioned when there's a crisis or after decline has happened or at the end of life. But in some homes, we can see there is that necessary reframing, in my opinion, where maybe it's being introduced early and there's a team-based approach to providing palliative care. I'm seeing Alma writing, we have our volunteers support palliative care and end of life. So that's really great to hear. Definitely, I'll emphasize again, it's a team sport. So you don't just need a specialist like me. You don't just need any doctor. There has to be a really interprofessional, interdisciplinary approach. And that would include volunteers. I've seen kitchen staff being involved in supporting residents. I've seen cleaning staff being involved. And I see another comment. Crystal said, my mom spent a week in the PCU in the hospital. Now in palliative care back at our LTC, but is a world of a difference from the PCU. PCU was amazing, and there was even support for me. So, Crystal, I think you're speaking to some of my experiences I have had as a palliative care physician, because I've worked in long-term care, but also in many of these other settings. And I'll share with you that these disparities were troubling for me, where I really feel that the type of care that a resident would receive and the support their family would receive should not be dependent on their location within the healthcare system, right? You should really receive the same or similar care, across the board, right? That would be the ideal scenario. Okay, so thanks everyone for the great discussion. I think we can talk a lot more, but we'll move on to the next gap.
So another gap that we're seeing, we see it Amit sees it in clinical care. I see it in more the research side of things, and speaking with families and residents is issues around undertreated symptoms and undermanaged symptoms. So there are certain things, as your individual's health declines, they can often experience symptoms such as pain, exacerbations of dementia-related symptoms, shortness of breath, anxiety and psychological distress, and confusion. And it's really important that these symptoms are managed to support a resident's comfort and their quality of life. And that can include medication management, which is often one of the primary approaches. There's also, at times, there can be non-pharmacological approaches. But what we're seeing is that there's issues of undertreating these symptoms. We've done work to look at medication management in relation to common end-of-life symptoms. And we see that, some residents in long-term care homes are not receiving medications that they may potentially benefit from. And, it kind of gets back to that point also around variability across homes. There's a lot of variations in homes. So one thing, we wanted to have a little bit of a poll, as I mentioned. So we wanted to get a sense of individuals' experiences with symptom management. So the question that we're posing to everyone is, do you feel your family members' symptoms are or were well managed in long-term care? And so here's the, again, the Slido QR code, as well as the website with the join code. So we'll just give everyone a couple of minutes to provide their input. We're also happy if you want to drop something in the chat or, bring something up in the discussion, we can open the mic up to you.
While folks are answering, I just wanted to point your attention to a question in the Q&A from Lynn, asking, is there not a national group within medicine that agrees in providing direction on what palliative care really means? It seems very fragmented, and palliative care actually should start, as you said, in the home before long-term care is even considered, at a time of diagnosis.
Yeah, so Colleen, if it's okay, maybe while answers are coming in, I can take I can start answering that question. So absolutely there is. I used to be on the board of the Canadian Society of Palliative Medicine, which is one of the national organizations representing palliative medicine in Canada. There's also the Canadian Society of Hospice and Palliative Care. There's multiple actually national organizations. We have a national framework on palliative care here in Canada as well, which provides some sense of direction and also definitions, shared definitions, as I've alluded to, as to what palliative care is. And what we've spoken about is in line with what all these documents and professional societies have been saying. Part of the reason for fragmentation, in my opinion, is honestly related to funding issues and priorities within the healthcare system. I'm not the Minister of Health or Long-Term Care, so this is just really my frontline perspective that, as we know, there are many competing priorities in today's world and in the healthcare system as well. So that's part of the challenge. And I'll share with you part of the issue is that, unfortunately, here in Canada, we don't have palliative care covered under universal health care. So the Canada Health Act does not include access to palliative care in Canada. So that doesn't mean that people are not getting access. Clearly, people are getting access, but that often leads to the fragmentation that is developed within the system. The second issue is around education with respect to palliative care. So very unfortunately, you can, there's no requirement to have even basic education in palliative care to work in many different healthcare settings, including long-term care. So that often leads to the fragmentation as well, where you may, by chance, encounter a long-term care home or staff within that home who are very passionate, very dedicated, have a lot of expertise and education around palliative care. But then, unfortunately, there may be other people who are, of course, very well-meaning and still very hardworking and have their own expertise, but perhaps have that gap in knowledge with respect to a palliative approach to care.
So thank you to everybody who's provided answers to the poll. So we can see, the largest group is individuals who are saying that they do not feel that their family member symptoms are or were well managed. So, this aligns with what we see and what we hear. A smaller group say sometimes, and then an even smaller group say yes. So, it really points to the need for improvement around, symptom management and also more broadly palliative care within long-term care. Amit, now I'll pass it on to you to talk about the third gap.
Yeah, so this is around advanced care planning, and we talked around, I started this conversation a little bit earlier. Honestly, this is the main focus of the work that I do in long-term care, or that I try to do, is really supporting residents and their care partners to have a conversation around what is going on with their illness, what their prognosis is, and what to expect and prepare for in the future. And then trying to think of a plan which is an informed plan, which would be in line with someone's wishes, and also understanding what medical treatment options would be available. What I've heard is that often these conversations, once again, are quite variable. In some long-term care homes, they happen quite frequently, but in others, not so much. There's a legislative issue here, as many of you might know, where the only mandatory care conference that has to happen is 6 weeks after a resident moves in, and then annually thereafter. But the issue is when there's changes in between where we need to have the conversation, that's, dependent on the skill of the home, the time that people have, and clinical judgment. So that's kind of an issue where sometimes people are not fully prepared about certain decisions. And I just wanted to pause there and just sort of say that can be incredibly stressful to be in a situation where you're trying to make a decision, possibly even a life and death decision for your loved one, but don't have all the information when you need it and in the amount of detail that you really require. So these are incredibly challenging and difficult decisions to make, and especially more so without that preparation aspect when you're under distress. So we have a poll that we wanted to ask you around if you felt prepared for the decisions that you were asked to make. And this is just a general poll. We would welcome any comments, any questions in the chat. Please feel free to unmute.
I did notice, Andrea, you had your hand up. I saw that you put it down, but if you would like To ask a question, you can put your hand up again, or maybe it was already answered, or you can also put it in the Q&A.
Yeah, so it looks like it's no or somewhat.
Yeah, so I think this, this kind of emphasizes what we're trying to do today and what we're, thinking about the future and how we can build better resources to support family caregivers in decision making and in making these often really challenging decisions that, depending on your background, there you may be really, you have a lot of information needs that are going unmet. Okay, I think I'll move forward because I think we had 9 responses on the last one. Just for the sake of time and to ensure we have time for discussion. So the fourth gap that we wanted to note, and this has already been mentioned, is just the amount of variability that we see across long-term care homes in Ontario. So, all homes in Ontario are governed under the same legislations and regulations, but there still exists a lot of variability in care practices and what's actually happening on the ground. And there's a lot of different reasons why that may be. There can be differences in resources and staffing. So we heard the question on do all homes have access to somebody like Amit? And the answer is no. So you're going to have homes where they may be very well resourced, and that may be internally in terms of the staff have a lot of training and expertise in palliative care, or they have external resources that they can go to. And then you'll have homes where those things are not available. There's differences in communication approaches across homes and just different approaches to care and the extent to which palliative care is embedded within the culture of long-term care. And all of these things can really impact how care is delivered in the homes and how homes think about and introduce palliative care and offer palliative care. And ultimately that can shape residents and family members' experiences within long-term care. So before we wrap up and move towards kind of thinking about where we want to go from here, we just want to emphasize the really vital role of family caregivers in long-term care, particularly when we're talking about palliative care and what happens in palliative care delivery and long-term care. So, family caregivers are really central to the decision-making that's part of palliative care and thinking about, advanced care planning and goals of care discussions. And what we're asking of family caregivers in those settings it's a lot for them to take on, and they need to be supported. Family caregivers are also really important advocates to support better care for their family members. So in work that we've done, we've talked with family caregivers and long-term care staff, and it's really highlighted how important it is for residents to have a family caregiver that can advocate for them and the differences that might happen if people don't have those advocates. So, really emphasizing that family caregivers have that really important advocacy role within the home and within the team, the staff team within the home, but also, advocacy from a system perspective and thinking about how can we improve the long-term care system to support palliative care delivery. So I think, Amit and I have worked together for a number of years now, and we see a lot of opportunities for us to be able to maybe partner with Family Councils Ontario to think, develop resources and tools that can support caregivers. So this may include practical resources for caregivers, information to help clarify, what decisions may arise and help people prepare for those decisions. So resources that are, understanding like what might you expect, what questions might you be asked to, or decisions might you be asked to make throughout your family members' admission and stay in long-term care. And also thinking about how we can develop resources that align and integrate with existing tools, such as the Family Councils Ontario Navigation Guide. So as our last poll, the questions that we had for you are, based on your experiences, what resources or tools would you feel would help you most? So we have a number of different options, understanding what to expect as your illness progresses, help preparing for medical decisions, such as decisions around hospitalization or CPR or artificial feeding. Information on knowing who to go to and how to navigate the healthcare system, other practical tools or guides to support decision making, or others. And you're welcome to drop them in the chat or bring them to the group. So I'll just open up the chat here, or sorry, the poll.
All of them. That's great. Thank you. And maybe I'll just add to what Colleen said, or re-emphasize, is that we're not here to reinvent the wheel. Like, there already are some excellent resources out there, including the Long-Term Care Navigation Guide developed by Family Councils Ontario. There's resources that have been developed by SPA LTC as well. You can definitely go to their website, but we're here to see what more can we provide and what would actually support you. And I'm seeing, in addition to the poll, something in the chat from Rachel, our good friend Rachel. I hope you're doing well. It says, please add to the list, emotional support with loss, bereavement, dying, and death. I think that's a really great point.
Mhm.
If you've seen this experience, and I'll be very honest, I don't have a loved one living in long-term care at this moment, although I am a caregiver for my elderly parents who don't live in the city. But I've definitely seen that really the process and the way the system is set up is not adequate, to say the least, with supporting family caregivers through grief and bereavement. I believe the room has to be cleared very quickly and people's belongings have to be removed because, of course, the system is under stress and there's a new resident waiting to move in. I think all of that needs to really be considered. And I hope that one day our system can provide more of a compassionate approach. Yeah, and Rachel has said, I think the emotional burden often makes the care decisions even more complicated and difficult, including family dynamics and other factors. Yeah, absolutely. I think it's a myth that we can ever be completely objective or unbiased. Definitely as a physician, I will never pretend that I have no bias at all in any situation. That's absolutely not true. We're all human. And especially when it's somebody that you love and care for, your loved one in long-term care, it's very normal that you would have emotions factoring in that into the decision. And I would actually say that that should be acknowledged, validated, and it's very normal. And that should be happening.
Yeah, so just looking at the poll results, I think it kind of resonates with Amit's selection of everything. There's broad interest in a lot of the different potential tools and resources and things that we're considering. So now, Amit, I'll pass it to you I think we've got the last slide and then some discussion questions.
Yeah, absolutely. Thanks everyone for all of your participation. It's really fun and great to see. So, in terms of developing resources, my colleague Colleen and I were hoping to work with Family Councils Ontario and take some of your feedback back to them and really think about how we can work with them to develop some type of resources. But we wanted to ask you about maybe the format of the resources that you think might work best for you. And this might depend on obviously what the leadership at Family Councils Ontario also feels. But just wanted to hear from you. Like, do you think printed brochures would be helpful? Maybe adding something to their website, videos where there's maybe a short conversation about a particular topic, an app, or maybe more of these sessions where we invite more family care partners, people who are leading family councils across Ontario to join in, share their experiences, maybe even ask about a particular topic, and then we would present on that. So yeah, feel free to unmute or feel free to type in the chat in terms of what you think would work best.
And then I'll move it forward to the broader discussion.
Okay, so I'm seeing from Alma maybe a website or some part of the Family Councils Ontario website. I see another comment here. Website. We have 2 votes for website. Brochure is available at doctor's offices, clinics. Thanks, Mona. Website. Okay. So it seems like there's a, at least for some of the responses, people are hoping that there would be some website resources available. Right. Yeah, feel free to, as we continue this open discussion, feel free to continue to provide your feedback in the chat if you agree with website or you feel another format would be helpful. Now, just to kind of wrap up our presentation today, we just wanted to have some open discussion with all of you, just to learn a little bit more detail. If you wanted to share, if you wanted to unmute or type more in detail with the chat in terms of more specifics about your experience, what is working well in your long-term care home and what can be improved. So Crystal is writing, I would like in-person sessions in the long-term care homes. For that, would you mean for the family council in the long-term care home? Just to kind of, ask some questions or talk about a palliative approach to care and how to improve it at your specific home or in any home? Is that what you're referring to? Yes, and families in general. Okay, so more education, sort of on the ground in long-term care. I definitely agree. In person, if it can be done, is always better. It's my experience that it's better for sure. Alma has written in-person training in a long-term care home since I will be opening up a new home. Wow. Yeah, absolutely. Alma, we'd love to learn more about where you're opening up your new long-term care home and what the name will be and what that home will look like. Okay, I'm assuming you're asking for our email. I can provide my email in the chat if that's helpful. Okay, yeah, absolutely. And I can connect you to my colleague as well, Colleen. So if you email me, you'll be connected to both of us. Okay. Yeah, anyone else want to share their experiences?
Something came in the Q&A box.
Oh, yes, I missed that. I'm monitoring the chat. Okay, so I'm seeing here universal comfort strategies prioritized for all long-term care residents across all homes, such as seating, positioning, use of headrests, etc. So maybe things related to non-medication management to make sure residents are well cared for. And I absolutely agree. Perhaps that should be something that should be assessed. It should be part of the care plan. We know that the PSWs would really play a big role in making sure some of those measures are implemented. Definitely important for residents without frequent family visits. So you bring up a really good point that, there's many different circumstances that happen for people as they age and they become older and they're living with a disability in long-term care. And some people very sadly don't have family caregivers who are very involved, or sometimes they have no family at all. So that's very important to acknowledge. Educational and proactive strategies. Yep, absolutely agree. That's really important. I see in the chat from Lori, working well and can be improved, as Rachel mentioned, emotional support for family care partners with loss, bereavement, dying, and death, including anticipatory grief for those with family members and friends with diagnoses that impact the entire care circle. We have partnered with our local hospice organization to help us with grief support in groups, individualized support, and workbooks. That's amazing, actually. And I think that's how we need to think in long-term care. We need to really think beyond the walls of the actual building and really need to think about building those community connections. All right. So maybe we'll just move to the next slide in the interest of time. Okay. I think we've talked about a lot of things, frankly, but maybe we'll just ask, maybe the last two questions in this slide. Like, if you really had to pick one thing, what do you think would really make the biggest difference for family caregivers? It sounds like to me something on the website to support decision making would be a very valuable tool. But please feel free to correct me if I'm wrong or think of a different idea. Once again, you can put your answer in the Q&A or in the chat. We'd really love to hear from you. All right. Colleen, anything to add?
No, nothing that I can see. I think there's a comment in the chat. Huge gaps in private retirement homes as well. Absolutely. That's a growing sector.
Yeah, completely agree.
And I think another thing that we would be interested in understanding is, as we move forward is, are there other resources that you have used or seen that you think, we could kind of build from, recognizing that there's others in the space. Amit, you mentioned SPA, LTC, thinking about, so we have a comprehensive understanding of what's out there and, how we can fill the gaps or maybe, like bring people together. Because the palliative care world is small enough that, we can think about FCO, we've got the SPA LTC group, like different people that we could partner with. They're all kind of within our networks.
All right. So I provided my email in the chat, and I'm assuming you would have Tae Young's email. So, oh yes, okay, thanks, Colleen. So, yeah, please feel free if there's something else you think about afterwards. You can definitely, please feel free to contact us, right? And we'd love to hear from you. I see from Vivian, I keep hearing about the number of patients who have no advocates. Yeah, that's very true. And that's something I'm seeing as well. So thank you for mentioning this. I would like to see the community involved in becoming advocates. We wring our hand, but we need to think in strategic terms. Yeah, absolutely agree. And we know that people who are socially isolated maybe don't have support from family caregivers, maybe because they don't have any family, often have worse healthcare outcomes. Brian mentioned speaking to the Alzheimer's Society. I think that's a great idea as well, given how prevalent, as we know, dementia is in long-term care. So thank you for sharing that.
Stop sharing now. Thank you, everyone.
Yeah, I think we're having some more comments coming in. From Lori, biggest difference would be increasing education about palliative and end-of-life care, what that looks like. To the average person who does not work in long-term care, clinician-based, has ever seen the active dying process before. I see social media is trying to break down barriers of what death looks like and has helped many that I've spoken with. Yeah, absolutely. I think social media is a great tool to advocate for better care. I completely agree. Yeah, and Mona has written, thank you for the informative session. Thank you for attending. Will you be sharing the slide deck? Yeah, I don't have any issue. Colleen, do you have any issue with sharing the slide deck?
No,
yeah, absolutely. Very happy to share the slide deck.
And I can share the slide deck with everybody once the webinar has been uploaded to YouTube, so you'll have the recording and the slide deck as well if you want to view it or share it with anybody who wasn't able to attend today. I don't know if there's any more questions or comments coming in. Colleen, Amit, is there any final closing remarks that you would like to share?
No, I would just say thank you to everyone for attending and for participating and providing your thoughts. And hopefully this is just the start of, working together.
Yeah, and I'll echo Colleen's comments. Thank you, everyone.
Thank you very much, Amit and Colleen, for your presentation today, for sharing your knowledge, sharing a lot of information, and leading this discussion. It was very informative, and I'm glad that we were able to all share our stories and learn from each other. As I mentioned, this webinar has been recorded, so you will have access to this. And if you have any questions, you have Colleen and Amit's email, but also you can connect with me and I will pass any questions to our guest speakers. Our next FCO webinar is scheduled for April 22nd, which is also a Wednesday, 12 to 1. It is a collaboration with Carp Ottawa. We have done a lot of events with them, so this is just the next one in our series. I'll share the registration link in the chat if anybody is interested in attending. And yes, well, thank you so much to everybody for being so participative and engaged today. And we look forward to seeing all of you at our next events. Thank you and have a good day, everybody.